Welcome back to Anatomy and Physiology online. Still the same materials, just transitioning to an online format. And we're just picking right back up where we left off, which is skeletal system. And we're going to finish off the skeletal system with chapter 9, talking about joints. And when you think about a joint, it's really just a location. And when you think about the location, it's primarily where bone meets bone. But technically, there are actual other things in your body that classify as a joint. For example, remember we talked about the epiphyseal plate. Remember that's cartilage found in kids separating the epiphysis from the diaphysis. Technically, that is a joint. Sometimes when cartilage meets bone, we classify that as a joint. Another example is your teeth, where your teeth fit into your jawbones. Technically, your teeth aren't bones, but they're hard because they're made up of a lot of the same minerals and ingredients that your bones are made up of. So where your teeth fit into your jawbones, that's actually a joint. So when you think about it, you have tons of joints in your body. Remember, you have over 200 bones in your body, and a lot of those bones meet together. So like usual, you're going to have a lot of joints. And like usual in anatomy, when you have a lot of something, what are you going to do? Well, you're going to classify them. And when we look at joints, we find two ways to classify them. One way is structurally, and another way is functionally. And when we talk about structural classes, you're really talking about what's holding the bones together. And when we talk about functional classes, we're really talking about how do you move at that joint. So we're going to go through these two major groups of classification. We're going to look at structural classes of joints, and we're going to look at functional classes of joints. As we go through each of these structural and functional classes, I want you to know each of them. And these are just big categories. So we're going to look at the different types of structural classifications of joints. And for each of those structural classifications, I want you to know the three major groups, an example of a bone or joint, in that group, and really what's holding the bones together, because we're talking about structural classes. It turns out there are three major types of structural classes. There are fibrous joints, cartilaginous joints, and synovial joints. I want you to know these three structural classes. And then we got to know, how are these classes holding the bones together? What's going on in each of these structural groups? So we're going to go one by one, focusing in on them kind of briefly before we go into more detail in the next couple slides. So first up is a fibrous joint. Okay? Remember, in anatomy, their names always give you a hint, like this one. It's called a fibrous joint because connective tissue fibers are holding the bones together. That's all it means. To be a fibrous joint means that you have connective tissue fibers holding the bones together. And an example of that is actually where your teeth fit into your jawbones. Your teeth are held into the jawbones by tiny little fragments of connective tissue. This is why if you've ever had to pull out a tooth yourself, or if you had a little kid who you've had to pull a tooth out, you might notice when you pull out the tooth, sometimes that tooth looks like it's dangling by a string. Well, technically, it kind of is. It's dangling by connective tissue fibers. When you tie a little string around your kid's tooth and then tie it to the door and shut the door and hope the kid's head doesn't go flying with it, you're really trying to rip the connective tissue fibers holding the tooth and connecting it to the jawbone. That's how your teeth stay in your jaws. It's a type of fibrous joint. Another example is actually the sutures of your skull. Remember, we saw this in lab before the break. Remember, those sutures look like little cracks on the surface of the skull. And if you were to zoom in on one of those sutures, you would actually see little connective tissue fibers connecting the individual bones of the skull together. So your sutures are technically a fibrous joint. They're connected by connective tissue fibers. Another structural class of joints is the cartilaginous joints. Again, it's telling you in the name. It's called a cartilaginous joint because cartilage is holding the bones together. It does not matter which type of cartilage. Remember, we saw three types: hyaline cartilage, fibrocartilage, and elastic cartilage. Doesn't matter what type of cartilage. If it's separating or joining bones, it's a cartilaginous joint. And an example is something we've seen already. It's the epiphyseal plate. Remember, the epiphyseal plate is in kids, separating the epiphysis from the diaphysis. So technically, kids at their epiphyseal plate have a cartilaginous joint. Another example is down in the pelvis. Connecting the left and right pubis bones is a little bit of fibrocartilage called the pubic symphysis. Well, your pubic symphysis is fibrocartilage, and it's located between your two pubis bones. So technically, that's another cartilaginous joint. It's just cartilage holding the bones together. And the last structural class is a synovial joint. To be a synovial joint simply means the joint will have a synovial membrane making a synovial fluid. Remember, they always tell you in the name. A synovial joint just has a synovial membrane making synovial fluid. Why? It's to have nice and easy movements in the joint. Turns out an example of a synovial joint is pretty much any joint you can move very easily. Kind of like your knuckles. You can move your fingers pretty easily because all the joints in your fingers and your knuckles are synovial joints. That's why when you crack your knuckles, you hear a popping sound. Okay. Turns out that popping sound is just you moving around a little gas and some synovial fluid. So turns out somebody lied to you. Turns out grandma, grandpa, mom, dad, whoever raised you, they lied to you. Why did they lie? They told you to stop cracking your knuckles, otherwise you're going to get arthritis. They lied to you. How did they lie to you? Turns out, when you crack your knuckles, you know what's going on. You're just moving gas and fluid around. That's not going to give you arthritis. So it turns out you could crack your knuckles all you want. If you end up getting arthritis, well, you were going to get it anyway. Not because you were cracking your knuckles. But that's pretty much what a synovial joint is. A synovial joint has a synovial membrane making synovial fluid for nice and easy movements. So think of any joint you can move pretty easily, and sometimes you might hear a pop because you're moving fluid, like your knuckles or your knees, possibly your shoulders. Lots of movements here because you have all this cushioning from the fluid and synovial membrane. Those are your structural classes. Now we go on to the functional classes of joints. Turns out there are also 3 groups of functional classes of joints. And I want you to know your 3 functional classes. How are you moving in that class in the joint? And an example. So let's go through them. There are 3 of them. There are synarthrosis joints, amphiarthrosis joints, and diarthrosis joints. Those are the 3 structural classes. And again, we're going to go one by one, starting off with the synarthrosis joints. And again, their names, like usual, tell you what's going on. An arthrosis, S-I-S at the end, is a joint, singular. Arthroses, S-E-S at the end, is plural. So that just means joint, arthrosis. And syn means without. So what is a synarthrosis? What is that joint missing? This is a joint that has no movement. That's a synarthrosis joint. It has no movement. And where do you have bones held together that have no movement? Turns out it's, again, those sutures of the skull. Remember, they're held together by connective tissue fibers, and those fibers are actually preventing the bones from moving once you're an adult. So when you think about your sutures are fibrous joints structurally, because they're held together by connective tissue fibers, and they're synarthrosis joints functionally because they can't move. Remember, you got to know how the joints are related. Let's try another one. Another type of functional class of joints is the amphiarthrosis joints. Amphiarthrosis joints are joints that have a little movement or a slight movement. If you can move the bones just a little bit in the joint, that's an amphiarthrosis joint. An example is something, again, we've seen before. It's the pubic symphysis. Remember, pubic symphysis is just a little bit of fibrocartilage connecting the left and right pubis bones. So technically, that is a cartilaginous joint structurally, but that cartilage is a little flexible. Kind of think the cartilage in your nose or your ears. It's a little flexible. So when you have cartilage holding bones together, the bones are going to be able to move just a little bit. So your pubic symphysis, which is a cartilaginous joint structurally, is an amphiarthrosis joint functionally, because that cartilage allows for a little movement, like in the pubic symphysis. Another example is the discs in your spine. Remember, the discs in your spine are called the intervertebral discs, And they are, again, fibrocartilage. And again, this is cartilage, which is going to allow for a little movement. This is allowing you to bend forward and backwards just a bit. Why? Because your spine is made up of lots of amphiarthrosis joints. Every single intra-articular disc is an amphiarthrosis joint, allowing for some movement. Then the last functional class is a diarthrosis joint. Diarthrosis joints, by definition, have lots of movement. When you see the term free movement, that means that it's a lot of movement. It's not restricted. So think of any joint in your body that you can move a lot. Again, that's things like your fingers. Your fingers can move a lot because the joints move a lot. Your knuckles, your shoulders, your elbows, your hips, your knees. Any joint you can move a lot, aka free movement, that's a diarthrosis joint. And most of these joints that you can move a lot is things partly to you having a synovial membrane, making a synovial fluid to help reduce friction, to provide cushioning, so you have lots of nice and easy movements, because these joints move a lot. Those are diarthrosis joints. So name any joint you can move a lot, like the knee, which we'll see later on in this chapter. You can move a lot in the knee, so it's a diarthrosis joint functionally, and you might on occasion hear a pop in your knee as you move around gas and synovial fluid made by a synovial membrane. So your knee is also a synovial joint structurally. So those are the two major groups of classifications for joints. There are structural classes, how do you hold the bones together, and functional classes, how do the bones move. We're going to repeat this one more time up close, kind of combining the two, just reminding ourselves. That's all the next couple slides are doing. Yeah? Kind of reminding ourselves of the structural classes and relating them again to the functional classes. So first, again, just to revisit, is a fibrous joint. Remember, in a fibrous joint, you have connective tissue fibers holding the bones together. And usually they're very dense, regular connective tissue fibers. Kind of think almost like tendons and ligaments. So when you have connective tissue fibers holding the bones together, that's a fibrous joint. You remember an example are the sutures of the skull. If you were to zoom in on the sutures of the skull, you would see tiny little fibers holding the bones together. So it is a fibrous joint. And you remember those fibers are keeping the bones from moving. So this is also a synarthrosis joint functionally. Remember, same thing for your teeth sitting in your jawbones. As your teeth and your jawbones are healthy, there should be no movement. Remember, your tooth is stuck to your bone by small connective tissue fibers, and it should not be wiggling unless you're a little kid about to lose the tooth. Why? Because your gum physis, which is the name of the joint where your tooth sits in the jaw, that's a gum physis joint. It is a fibrous joint structurally and a synarthrosis joint functionally. Another joint to remind ourselves of are cartilaginous joints. Remember, all it means to be a cartilaginous joint is that you have cartilage holding the bones together. And you remember an example we saw was the epiphyseal plate in kids, where you have cartilage separating the epiphysis from the diaphysis. And even that pubic symphysis adding or connecting the left and right pubis bones. Those are cartilage holding bones together, so those are cartilaginous joints. And again, you remember that cartilage is going to allow for some flexibility, some slight movement. So functionally, these joints are amphiarthrosis joints. And then the last structural joint class, again, is the synovial joint. Remember, to be a synovial joint just means you have a synovial membrane making synovial fluid within the joint. And that fluid is going to help to reduce friction to allow for nice and easy movements. So you're going to move a lot in these joints. So don't forget, synovial joints structurally are diarthrosis joints functionally. Think the joints in your fingers. Think your knee joints, your shoulder joints. Any joint that has a lot of movement is usually a synovial joint. So those are your structural and functional classes of joints. So to finish off this chapter, we point out a couple structures commonly found in your joints, as well as talking about how do you move at these joints specifically. And next thing we're going to look at are just some structures that are also found in some of your joints. There's something called a bursa, and something called a tendon sheath. If you use a different textbook, they might call the tendon sheath a tendinous sheath. So what is a bursa and what is a tendon sheath? These are the structures that we tend to find in some of our joints. Starting with a bursa. All a bursa really is, it's a fluid-filled sac. Think a pillow or a water balloon. It's just a fluid-filled sac to provide cushioning and to reduce friction. So you tend to find bursa in a lot of your diarthrosis joints. Joints that need to do a lot of movement will tend to have this extra cushion to help reduce friction to allow for those extra movements. That's a bursa, a fluid-filled sac to reduce friction for cushioning. Why? So you could have nice and easy movements. Then another structure we tend to find in joints are what we call tendon sheaths, or sometimes called tendinous sheaths. These are basically a bursa that have been stretched out and wrapped around the tendon. So again, think about having your water balloon, but now stretching out your water balloon and wrapping it around the tendon. It's still a fluid-filled sac, it's just wrapped around the tendon. And it's still doing the same thing. It's providing cushioning, reducing friction for easy movements. That's it. A bursa, fluid-filled sac, a tendon sheath, a fluid-filled sac wrapped around a tendon, and they're both pretty much doing the same thing, reducing friction, providing cushioning for easy movements. And when we think about that, you're going to have lots of movements in some of your joints, especially your diarthrosis joints. So we're going to have to talk about movements, which we'll do next. Like most things, there are going to be lots of movements in your body because you have lots of bones and lots of joints. And a lot of those bones and joints are comprising diarthrosis joints. So we're going to have to talk about lots of movements, especially in these diarthrosis joints. Like usual, there are lots of different types of movements. You're only responsible for the ones that we're going to approach and go over in this recording today. Remember, stick to your exam review, trust the exam review, and email me if you have any questions. So as we go through these movements, I'm going to give you the term for the movement, and then I'm going to define it, and basically going to ask you to kind of give me back that definition on your exam. Or I could describe a movement on your exam and ask you to name what just occurred, which is basically, again, the definition. And again, only stick to the ones in this recording. So again, there are lots of movements, but we're just going to pick out a handful, starting off with two major movements. And again, a lot of these movements and their names make it into our everyday vocabulary, like these two, flexion and extension. Most people know how to flex. Most people know how to extend. But if you ask them the definition, they're not going to know. Okay? Remember, you got to know anatomical definitions. So let's go through them. What does it mean to flex? By definition, to flex is to decrease the angle of a joint. So when you flex to show off your biceps, you're really decreasing the angle in your elbow joint. That's how you flex. It's decreasing the angle. An extension is the opposite. So what's the opposite of decreasing the angle of a joint? Well, it's increasing the angle. To extend is to increase the angle of a joint. Turns out when you lift your head up to look up at the sky, you're extending in your neck. You're increasing the angle of the joint in your neck to allow you to turn your head to look up. That's flexion and extension. Again, more movements, and again, a lot of them still make it into your everyday vocabulary, like the next two. There's abduction, A-B as in boy, duction, and adduction, D as in dog, adduction. Well, most people have heard the word abduct. To abduct someone is to take them away. So what's the anatomical definition for abduction? Abduction. To abduct is to move away from the body. So if you have your arm at your side and you raise it up, like you're doing lateral arm raises, you're abducting the arm. You're pulling the arm away from the body. And to adduct, a deduction, like you're adding, is to add it towards the body, to go towards the body. That's adduction. So when you bring your arm back down towards your side, you're bringing it towards the body. You're adducting the arm. So abduction, go away from the body. Adduction, towards the body. Some movements are a little tricky, like the next one. It's called circumduction. Whenever you look at pictures of circumduction, it looks like the person's drawing a circle. But what's the definition? You remember, you got to know definitions. By definition, circumduction is actually 4 movements combined. By definition, circumduction is adduction, abduction, flexion, and extension. That is the definition. Circumduction is adduction, abduction, extension, and flexion. All 4 previous movements in one. Kind of imagine if you wanted to draw a circle with your arm. For you to draw that circle, at one point, you got to pull your arm away from your body. That's abduction. Then you got to bring it forward. That's flexion. And continue to abduct, bring it away from the body. Then you bring your arm towards the back. That's extension. Then you got to kind of bring it towards the body. Adduction. You got to do all 4 of those movements to draw that circle. It's abduction, adduction, flexion, and extension. That's circumduction. Keep going. We got a couple more movements to get through. We're going to skip over medial and lateral rotation. You do not need to know medial and lateral rotation. Those are more of a twisting and turning. If you turn to the side, lateral rotation. Turn back to the midline. That's medial. But we could skip those. The next ones I want to finish off with are ones that we find in specific places. For example, there's a movement that occurs in the ankle and foot. It's called inversion. And another one is called eversion. Happens in the ankle and foot. First is inversion. In inversion, you have the sole of the foot face the midline. So kind of think the bottom of your foot will face the middle or the inner part of your body. That's inversion. Having the sole of the foot face medially. And eversion is when the sole of the foot faces laterally. When the bottom of your foot faces the lateral side. That's it. So when you walk kind of on the sides of your foot, same side as pinky toe, well, the sole of your foot, the bottom of your foot, is going to face more medially. That's inversion. And if you walk more on the inner part of your foot, more on the big toe side, the bottom of your foot is going to face laterally. That's more eversion. Keep going. Your ankle and foot have some more weird movements in them. Another one is dorsiflexion and plantar flexion. Again, stick to these definitions. First is dorsiflexion. In dorsiflexion, you have the toes up and the heel down. That's dorsiflexion. Toes up, heel down. Turns out you dorsiflex every time you take a step. Every time you're about to take a step, people tend to dorsiflex. They tend to put their heel down and toes up. That's dorsiflexion. And plantar flexion is the opposite. Plantar flexion is toes down, heels up. Kind of think when you're pushing on the gas pedal in your car, you're plantar flexing. Or when you tiptoe, you put toes down, heels up. You are plantar flexing. So next time someone tells you to stop tiptoeing around the house, say, I'm not tiptoeing, I'm just plantar flexing. And they'll look totally confused. 2 more major movements. 2 more major groups of movements. Next group is what's occurring in the wrist and hand. It's called supination and pronation. Again, stick to anatomical definitions. First is supination. In supination, you have the palm of the hand go from facing posterior to anterior. That's supination. When the palm of the hand goes from facing posterior to anterior, that is supination. Kind of think of if you're asking for some soup. Please, sir, may I have some soup? I don't know if that's Oliver Twist or David Copperfield. I can't remember. But for him to ask for some soup, he has to have his palm go from facing posterior to anterior. That's supination. And let's say he gets his soup and he tastes it. It tastes nasty because they poured it in his hand. He has to pour it out. Okay? Well, for him to pour soup out of his hand, he has to do the other movement. It's called pronation. In pronation, it's the opposite. In pronation, the palm of the hand goes from facing anterior to posterior. That's pronation. And then one last movement occurs specifically in the hand. It's really the movement of the thumb. It's called opposition. Opposition, by definition, is your thumb's ability to touch the other fingers. When you can have your thumb touch the tips of your other fingers, that is opposition. One more time, opposition is your thumb's ability to touch the tips of the other fingers. That is opposition. And those are the major movements that we look at in this chapter. And in case you need some definition help, there are tables in your lecture PowerPoint. Table 9.1 has a lot of these definitions we just went over. And remember, there are lots of movements. Only stick to the ones we went over. And there are even other types of classification for movements in terms of the axes on which you could move, which are the X and Y axis. You do not need to know these axial movements. There are uniaxial movements, meaning you could either only move on the Y axis, up and down, or X axis, left and right. There are biaxial joints, which can move on both the axes. You can move it up and down, y-axis, and left and right, x-axis. And there is even a triaxial joint, but you do not need to know these movements. You do not need to know the uniaxial, the biaxial, or the triaxial movements. Only stick to the movements we just did earlier. So to kind of finish off this chapter, we're almost done with it. We look at how things could affect the joints. We're going to look at the anatomy of a specific joint up close, and we'll finish off with, like usual, what happens when you get old. So now that you know what your joints look like, at least structurally and functionally, we could talk about things that could impact your joints. Turns out lots of things, like usual, have a say, so to speak, in how your body could function. For example, we saw the way you look will impact the way you can move. So the structure of the joint will have a say in how the joint will function. Turns out, not only that, muscles have a say. A lot of your joints are kind of stabilized by muscle, like your knee joint. So if you ever experience knee pain, one thing your doctor might do is send you to physical therapy to help strengthen the muscles of your thigh to help out the knee joint. Because the strength of your muscles and how they're arranged will affect your knees. What else could affect it? Kind of think, from way back in chapter 1, there were tiny chemicals that could boss things around in your body. Oh, you remember, what did we call those tiny chemicals? Oh, yeah, remember they're called hormones. Remember, hormones, coming from the endocrine system, are just chemicals that could tell other parts of your body what to do. And there are hormones that will affect your joints. They will boss things around and affect your joints. And lastly, usage. You have to use a lot of your joints. They're there for a reason, for you to move. And if you don't move at that joint, after a while, you might notice the joint's going to act differently, mainly get stiff and possibly painful. Why? Because you're not using it. When you do not use a joint, we call that disuse, and that will have an impact on the joint itself. Again, stick to the exam review, still the same. Now, we're going to transition and look at the anatomy of a specific joint up close. And in your lecture PowerPoint, I have lots of pictures of different joints. Like usual, I'll leave these pictures in here in case you want to use them to help you to study for lab. But we'll kind of skim over a couple joints and focus in on the one that we really want to look at, which is the knee joint. But before we get to the knee joint, just going to kind of briefly glance over other joints. Like this one here. It's called the temporomandibular joint, sometimes called the TMJ. It tells you, like usual in the name, where to find this joint. It's called the temporal, for temporal bone. Remember, that's the bone on the side of your head. And mandibular, for your mandible. Remember, that's your lower jawbone. Your temporal mandibular joint is where those two bones come together. It's where your lower jaw will actually fit in with the rest of your head. Your lower jaw is attached to your temporal bone at the temporal mandibular joint. But no, you don't need to know that joint. Another joint is the shoulder joint. Your shoulder joint is comprised mainly of your humerus and scapula. And from the picture in your lecture PowerPoint, you could actually see bursa and a tendon sheath in the picture. The little blue kind of water balloon looking structures, those are bursa. One's located under the acromion and one's located more on the anterior surface of the scapula. They look like little fluid-filled sacs. Those are bursa. And if you notice, you see a tendon of the biceps muscle going to attach to the scapula. And you see a little blue structure wrapped around the tendon. It is still a fluid-filled sac, but now it's wrapped around the tendon. You're looking at a picture of a tendon sheath. But again, we're not going to explore the shoulder joint. We'll see that in lab. So we'll progress on. It's the elbow joint. You can see from the picture in your lecture PowerPoint, your elbow joint is held together by a lot of connective tissue fibers, but there is some cartilage here, and there is a synovial membrane making synovial fluid, which is why you can move a lot in your elbow joint. But again, we don't need to know this joint, so we'll skip this picture as well. Coming down into the lower limb, we get to the hip, your hip joint. Again, like other joints that have lots of movements, when you look at it, you'll find a synovial cavity, which is just the location for your synovial membrane making synovial fluid. That's why you could, again, move a lot at the hip joint. But finally, we've made it to the joint we actually want to explore for lecture. It's the knee joint. And like usual, any pictures on your exam will come from your lecture PowerPoint. And the one picture is of the knee joint, where we see a lot of ligaments holding the bones together. You're only responsible for these 4 major ligaments. There's 4 of them. There's the anterior cruciate ligament, the posterior cruciate ligament, the fibular collateral ligament, sometimes called the lateral collateral ligament, and the tibial collateral ligament, sometimes called the medial collateral ligament. Make sure you know where these 4 ligaments are and you're able to identify them in the picture in your lecture PowerPoint. So let's talk about them. First is your anterior cruciate ligament. And like usual, you might have heard about this ligament before. You just probably heard it by its abbreviation called the ACL. If you ever heard of an athlete tear their ACL, they tore their anterior cruciate ligament. Where is this? This is a ligament that's attaching the femur up top to the tibia below, and it's located in the middle of the joint. When you look in the middle of the joint, you'll see a large connective tissue fibrous structure connecting the femur to the front of the tibia. That's your anterior cruciate ligament. And if you look behind it, you see another connective tissue structure going from the femur up top now towards the back of the tibia, because it's behind, it's in the back. It's in the posterior region, so we call it the posterior cruciate ligament. Your posterior cruciate ligament attaches the femur up top to the tibia down below, just more in the back. Then we even see ligaments on the sides. For example, you see a ligament going from the femur up top down to the fibula down below. And because it's going to the fibula, well, it's going to give you that hint in the name. It's called the fibular collateral ligament. And your fibula bone is lateral in your leg, meaning it's pinky toe side in your leg, while tibia is medial side, it's big toe side. So because your fibula is the lateral bone, that ligament going from the femur to the fibula, the fibular collateral ligament, is also sometimes called the lateral collateral ligament, because your fibula is the lateral bone in your leg. Then on the other side, again, is another ligament, again going from the femur up top. Now it's going down to the tibia. So we call it the tibial collateral ligament. And again, your tibia bone is the medial bone. So we sometimes call the tibial collateral ligament the medial collateral ligament. So make sure you know those 4 ligaments, where are they, and be able to identify them on a picture. Again, going from the femur up top to the front of the tibia, anterior cruciate ligament. Going from the femur up top to the back of the tibia, posterior cruciate ligament. Going from the femur up top to the fibula, fibular collateral ligament or lateral collateral ligament. And going from the femur up top to the tibia down below is the tibial collateral ligament or medial collateral ligament. And then to finish off the knee joint, we look at 2 other structures here. 2 structures to absorb shock, to provide cushioning. And they can provide cushioning, they can absorb shock because they're made up of fibrocartilage. Oh, remember we called these bits of fibrocartilage in the knee the menisci, plural, meniscus is singular. You have 2 of them. There's a medial meniscus and a lateral meniscus. They look like little C-shaped structures kind of sitting on the top of the tibia. One's medial and one's lateral. How can you tell them apart? Remember I told you fibula bone is lateral side and tibia bone is medial side. And so when you look at these two bits of menisci, one's sitting closer to the tibia side, the medial side, so we call it the medial meniscus, while the other one is sitting closer to the fibula side, the lateral side, so we call it the lateral meniscus. So make sure you could identify those structures: anterior cruciate ligament, posterior cruciate ligament, fibular collateral ligament, tibial collateral ligament, lateral meniscus, and medial meniscus. Be able to identify them on that bony looking picture of the knee, not the one showing muscle or real cadaver knees, just the cartoon depiction that looks mainly like bone with all the ligaments attached. Then to finish off this chapter, as I mentioned earlier, we're just going to talk about what happens when you get old. And by now, it's not good. Things go down the drain. Same thing with your joints. So what could happen? What can you experience as you get old? Well, it turns out as you get older, you begin to make less synovial fluid. And if there's less synovial fluid, there's going to be less cushioning in the joints. So your joints are going to feel kind of stiff. Not only that, from when we did our tissues lecture, you begin to lose hyaline cartilage. And you remember, when you lose hyaline cartilage, it will either not heal or heal very slowly. So as you get older, you're going to have less and less hyaline cartilage. And you're going to begin to have bone grinding against bone. Oh, that's going to hurt. And you're going to call it osteoarthritis. Remember, if you sit down, put your hand on your knee and kind of kick in and out, if you feel any snap, crackle, pop going on, you're starting to have bone grind against bone because you're losing hyaline cartilage. But don't panic. Remember, you're young now. You got a good couple years. But after a while, once you're older, you might want to take Tylenol in the morning to help you out. What else? Turns out as you get older, your ligaments become less flexible. They get stiffer and stiffer. This is why older people, when you look at them walk or run, move, they look very stiff, almost robotic, almost like they're being bound together. You're just seeing their ligaments get stiffer and stiffer as well. So overall, you're going to decrease your movements, or at least your flexibility, because you're losing your synovial fluid, you're losing your hyaline cartilage, and your ligaments are getting stiffer. But again, don't worry, don't panic. What can you do? You know the answer. What happens to grandma and grandpa when their joints don't work anymore? Oh, nothing big. They just replace it. Just go get a new one. We give a name to it. When you replace a joint with an artificial one, we call that arthroplasty. Arthroplasty is when you replace a joint. When grandma replaces her hip or grandpa replaces his knee, they just did an arthroplasty. But we can make artificial versions of a lot of the things we see, like in the knee. If you had to replace a knee, what's really going on? If you had arthroplasty on your knee, what's going on? Well, remember, in your knee, you could lose the hyaline cartilage and bone is going to begin to grind against bone, which will damage the bone. So if you have to replace the knee, you're going to have to shave away some of the bone in the knee. Mainly shave away the top of the tibia, possibly the back of the patella, and the inferior portions or the distal portions of the femur. And they'll just screw in artificial versions of all those things. And grandpa or grandma has had